This particular talk is going to look at totally arthroplasty in severe varus deformities, and often they are associated with a sagittal plane deformity of hyperextension or flexion. And this is a very common scenario where there is a severe varus deformity associated with a bone defect with lateral subluxation of the knee, and this is the bread and butter cases which we see. Now, why is the understanding of totally arthroplasty with severe varus deformity important? It has been shown in literature that there is a greater variability in results with longer operative times in severe varus deformity groups, and also the post-operative alignment of the varus deformity tended to be in residual varus, and we all know that if you leave an overall alignment of more than 3 degrees of varus, the long-term outcomes may be suboptimal. The use of technology has not been shown to be beneficial in these cases, and in knees exceeding 20 degrees of varus, no difference between CAS and conventional has been demonstrated when you look at the literature. Several potential reasons are listed, including inaccurate registration, residual instability, and possible errors with the radiographic techniques. So what happens in the severe varus deformity of the tibia and femur? Often they are accompanied by extra-articular components with metaphyseal or diaphyseal bowing. And on the tibial sides, this makes the accuracy of the tibial cut unreliable using technology. If you map the center of tibia as the center of the tibial spine, actually the center is shifted more laterally because of the metaphyseal bow. And this change may help in improving the accuracy. The first step for any severe deformity here is to classify this deformity. And we have this new, more comprehensive classification system which has been proposed by Dr. Parvizi and Ian Pont on the varus deformity. However, for practical reasons, we look at it in this way. Typically, you have the flexion varus deformity where the knee joint, it seems to be located, there is no subluxation, and these are associated with varying degrees of posterior osteophytes and flexion deformity of the knee. And on the other hand, you have the laterally subluxated knees, which are often correctable. And these knees are associated with hyperextension deformity. So the sagittal plane, you can have a flexion deformity or a hyperextension deformity. You must always be aware that the laterally subluxated knees actually are quite correctable. They are lax. And in these cases, the trick is to cut less amount of bone on the tibial side and then go slowly with the surgical balancing. Now, you can have combined metaphyseal deformity where there is extra-articular metaphyseal tibial deformity because of a overcorrected high tibial osteotomy or some sort of a malunited fracture or because of some anatomic bowing of the proximal tibia. And this tends to have a significant impact on the joint line because the deformity is close to the knee joint. And this is a case where there is significant metaphyseal bowing, and you can see that the anatomic axis of the tibia is cutting much more laterally as compared to the center of the tibial spine. It is important to get a long leg radiograph in all these cases in order to look at the location of extra-articular deformity, if any, and also to see what is the mechanical axis deviation, whether the deformity is in the femur, whether it's in the tibia, or whether it is both in the tibia and femur. Now, if you look at a short leg film for this particular patient, the post-operative radiograph appears to be in significant amount of valgus. But if you look at a long leg film, this is a patient who's got significant femoral bowing, and this surgery was done using computer-assisted technique, and you can see that the mechanical axis is actually restored. So the short leg film has got significant fallacies, and for all arthroplasties, whether it is severe deformity or less severe deformity, it is a good idea to make the plan for the coronal plane alignment on the long leg X-ray, which is standing.